Michael J. Klebuc. He's the Associate Professor of Clinical Plastic Surgery at the Academic Institute of Houston Methodist and also Weill Cornell Medical College. He's also the Director for the Center for Facial Paralysis Surgery and Function Restoration. And he said that's like 95% of what he does is facial nerve reanimation. So we're really blessed to have a true expert in this field speaking to us today. He obtained his medical degree from the University of Saskatchewan in '93. He's a Canadian and finally made it to the promised land way down in South Texas for some reason. He did his residencies in general surgery at Baylor and also in plastic surgery, as well as a fellowship in pediatric microsurgery at the Hospital for Sick Children in Toronto, Canada. And as I mentioned, facial reanimation surgery is his thing, what he does. I found out about Dr. Klebuc through Amy Silver, who does facial physical therapy. She spoke to our group back in May of 2017. And so we're really blessed to have Dr. Klebuc. So without any further introduction, Dr. Klebuc, it's all yours.
Well, thank you. It's a real privilege for me to be with you today and have an opportunity to talk about something that I'm really passionate about and enthusiastic for, and that is the surgical treatment of facial weakness and facial paralysis. Oh boy. There we go. So as we all know, injury to the facial nerve causes a series of both functional problems and aesthetic issues. One of the biggest problems is loss of the ability to blink and protect the eye, which can lead to dryness and sometimes even visual loss. Certainly, oral incompetence and drooling is a problem. We see obstructive breathing, difficulties with speech, all very problematic. And of course, from the aesthetic standpoint, it can also be a major issue. And so from a reconstructive surgery standpoint, our whole goal is to try to reverse these series of both cosmetic and functional issues to the best of our ability. When we look at the face, we try to break it into a series of zones. So we look at the brow, the periorbital region or eye area, the mid-face and the smile, and even the lower lip. And I try to come up with an independent plan for each one of these areas because you want them to function independently of each other and not have a mass motion. And that's really important. One of the most important things we're going to talk about today is timing. And I'm going to take you guys on a neurophysiology 101 class for about 30 seconds. And if you can see my mouse here, this is a nerve fiber. It carries a biologic electrical signal down to its associated muscle fiber. And at that terminal end, they communicate by releasing a series of neurotransmitters. They float across this gap. They land on these receptors. The receptors open the floodgates to calcium and the muscle contracts. So that is neurophysiology in 20 seconds or less. And so there's a very important relationship between the nerve and the muscle. And if the nerve gets separated, it's like pushing the button on a stopwatch. It initiates a time-dependent process of atrophy. And what happens is the receptors start to fade away, the muscle fibers start to be replaced by scar tissue, and this is progressive. And once you reach a period of 18 to 24 months where the muscle has been without its nerve, that turns into an irreversible atrophy. So if the nerve gets there later, the muscle really loses its ability to respond. So from a reconstructive standpoint, this is really critical because we would like to intervene as soon as we can to reestablish that relationship between the nerve and the muscle it serves. So when I was in training over 20 years ago, the mantra was this: if someone had an acoustic neuroma excised and was paralyzed after the surgery, as long as the nerve was grossly intact at the time of surgery, we were told to wait 1 year before considering any surgical intervention. Of course, as you're waiting, this atrophy process is continuing on. There have been some recent studies. One I'll show you today is from Johns Hopkins that sort of refute that to some degree. And in their study, they found that with cerebellar pontine angle tumors, such as acoustic neuroma tumors, if people are not showing any signs of functional recovery at 6 months and the EMG electrical testing is also silent, not showing any subclinical recovery, then you're better off to intervene at the 6-month interval. And that sort of takes the handcuffs off the reconstructive surgeons to some degree, because there's situations where we're pretty confident that we don't think that nerve is going to recover spontaneously. And so sitting and waiting and allowing this atrophy process to push on forward is less than ideal. When you look at facial reanimation surgery, it kind of goes into 2 basic groups, early and late. In the early group, those muscles of facial expression are still viable. You're within that window of opportunity to intervene. And so the whole goal is to restore a new source of innervation to those muscles. Sometimes that can be achieved by simply suturing the facial nerve together. Sometimes there's a gap, and so you can bridge the gap with a nerve graft. And other times you have to use local cranial nerves as transfers. And we'll get into that in great detail. We use the masseter nerve, the hypoglossal nerve, and even the contralateral facial nerve. But again, we'll drill down on that in great detail in a little bit. Once the muscle has undergone irreversible atrophy, then we need to bring in a new source of muscle. And that can be achieved by importing muscle using microsurgery. Often we'll obtain a small sliver of muscle from the inside of the thigh called the gracilis muscle, which comes with its nutrient blood vessels and its nerve. Or we'll use local muscles in the head neck region. The most common one we use is the temporalis muscle, which is one of the chewing muscles in this region, and it can be redirected. And again, we'll look at that in great detail. Last but not least, we also sometimes will use expendable portions of tendon or leathery tissue from the thigh called fascia to create an internal corset and give some static support to the face at rest. And it can just help with the overall balance and harmony of the face. So let's move on to nerve transfers. And specifically, we'll look at the 5 to 7 transfer, or the masseter to facial nerve transfer. So this is the masseter muscle. It's one of your chewing muscles. As I mentioned, the temporalis muscle does the same job, and it's just above it. It's in this area here. And what you can see is, here's the nerve that goes to the masseter muscle. It usually sends off early branch here, and then there's this long descending branch. And you can actually mobilize that branch and coapt it to a series of facial nerve branches in the midfacial region, and that can restore a smile. So here's an example. Young lady, she's undergone acoustic neuroma excision. She's now been a year out, and there's really not been any clinical recovery. So we went back to the operating room with her. She had a masseter to facial nerve transfer, and we also put in some tendon grafts to try to create additional static support. And so here she is about a year after her reconstruction, and clearly not perfect, but she does have some restoration of her smile. The question I get asked often is, well, does this hold up in the long term? And I think this is the answer. This is the same young lady, and she's now 16 years post-op, and you can see that certainly the effect of the transfer has been maintained. So the masseter nerve is really quite useful for these types of transfers. One, it doesn't create a functional deficit using the nerve, and there's several reasons for that. One is the masseter muscle is a chewing muscle, the temporalis muscle is a chewing muscle, so there's duplicated function. And so weakening the masseter muscle a little bit doesn't cause a problem. Also, as I showed you in those diagrams, we leave part of the innervation to the muscle alone so that it doesn't atrophy, it continues to function, and we don't create a cosmetic defect with it withering away. The masseter nerve has a very dense population of motor axons or motor fibers in it, so it's able to create strong motion, and we often see the corner of the mouth move very symmetric to the unaffected side. The nerve is very close topographically in location to the facial nerve, so we're able to get quite rapid regeneration. And we'll talk a little bit more about cerebral adaptation, which is pretty interesting stuff. So with regard to recovery, we typically see motion after a 5 to 7 transfer in young children at about 3 months. and then in adults, typically around 6 months. And it seems to be relatively independent of age for adults. The other thing that is fascinating is the masseter nerve, since the individual was born, its job has always been to chew. That's what it is. It's a chewing nerve. And so you have to train that nerve so that it knows it's no longer just a chewing nerve, but now it's a smiling nerve. And that's done by getting in front of a mirror and doing a series of exercises and getting the biofeedback effect of looking in the mirror. It's very important. And if people are diligent and they practice for about a half an hour a day, we find at the 2-year interval that 75 to 80% of people don't need to clench their teeth to create motion. They can just do it. And why does that happen? Well, this is what we think is going on. We think that there's actually plastic changes in the brain, or neuroplasticity. And we have these functional high-resolution MRIs. And when we ask people to bite, we can see on the motor strip in the brain, the area in the brain that represents biting, it lights up. We ask them for a volitional smile, the area lights up very close to it. So the chewing and biting and smiling are in very close proximity. And if we repeat the functional MRIs after the nerve transfer, we see the chewing area and the smiling area just merge together into one supercenter. So they've kind of cross-wired each other. And that's why people can learn to do this. There's actually neuroplastic changes within the brain. The other thing that's interesting is that a subsegment of the population already has cross communication between their masseter nerve and their facial nerve. And we know that by doing EMG studies. If we put electrodes into the chewing nerve and we tell people jokes or ask them to smile, we've seen about 40% of people that there's electrical activity. So there's some crosstalk between the two nerves. So that can be very helpful for helping people to learn how to use this particular transfer. Regardless, the motion you get from this type of transfer is rarely truly spontaneous. It can be reflexive and effortless, but it still is not truly spontaneous. And the one technique we have that can reliably produce spontaneous facial motion is called crossface nerve grafting. And the body is a pretty dynamic and wonderful machine, and it has 4 important functions: built-in duplication. And what do I mean by that? So anybody on this call pretty well today, if they had a loved one who needed a kidney transplant, could give up one of their kidneys as a donation and just do fine. And that's the concept of built-in functional reserve. We have a little more than we need in case we fall on hard times. And the same goes for the facial nerve. The branches, we have multiple branches of the facial nerve that go to the eye to produce eye closure. We also have multiple branches that make us smile and work the perioral region. And so I could take pretty well anybody on this Zoom meeting today to the operating room. We could explore their unaffected side of their face. I could divide half of the nerve branches that go to their eye and half of the nerve branches that go to their smile. And in the recovery room, they wouldn't notice any significant difference. And that's a wonderful thing, because it allows us, for example, to borrow function from the strong side and reroute it to the weaker side. And how do we achieve that? We use a series of nerve grafts. The most common graft we use is the sural nerve. And you can see here, the sural nerve runs from behind the knee to the side of the ankle. Its job is to give sensation on the lateral ankle. So it doesn't move anything. And because of that fact, you can use it as a nerve graft as spare parts. And we will connect those nerve grafts and bring them under the skin from one side of the face to the other side of the face. Now, what happens is the nerve fibers will slowly grow through this graft. The graft actually acts kind of like as a pipeline or a channel, directing them where they need to go. And they will regenerate at about 1 millimeter a day or 1 inch a month. So it will take those nerve fibers 10 to 12 months to traverse all the way across the face. This technique is very good for restoring resting tone to the face. It can also be very useful in restoring spontaneous eye closure. But when used as an isolated technique to try to create a smile, it usually is inadequate. It usually doesn't create enough strength to create a symmetric smile. And we have some strategies that we use to overcome that, which I'll share with you. We kind of partner it up with some other things to make it more effective. It can work extremely well for innervating or powering functional muscle flaps, and I'll show that to you a little later in the afternoon. Unfortunately, like many things in life, your nerve regeneration really declines with age, and so after 50 years of age, some of the effectiveness of this particular technique drop off. So as I said, the crossface nerve graft itself to make a smile can be inadequate. And so we partner it up with the Masseter to facial nerve transfer, which I just showed you. And it's to create a functional synergy. So we create a marriage of power and spontaneity. The power is coming from the 5 to 7 transfer, and the spontaneity is coming from the crossface nerve graft and the contralateral facial nerve. And this is how we do it. This is just a schematic showing how we have the 5 to 7 transfer and then the crossface nerve grafts. And we create that synergy. And here is a young lady. She's had a brain tumor removed 18 months before. And clearly she has some right-sided facial weakness. And here she is 15 months after the surgery I just showed you. And this is one of our Skype conversations. And you can see that there has been some improvement in her situation. So let's switch gears and we'll talk about the hypoglossal to facial nerve transfer. The hypoglossal nerve is the nerve that moves your tongue. And you can divide approximately 1/3 the diameter of that hypoglossal nerve and use an interposition graft to create a jump from the hypoglossal nerve all the way to the facial nerve. And the wonderful, wonderful thing about the hypoglossal nerve is that it has a constant release of neural input or output, pardon me. So it's this constant neural output that's being released from the nerve, a steady stream. And that allows the nerve to create very good resting tone in the face. And that stands in contrast to the masseter nerve, which is more like a light switch. It's on or off. You're either smiling or not smiling. The hypoglossal nerve is different. It keeps sending those neural inputs, and it allows the face to have much better symmetry at rest. And so I think for me in my practice, the hypoglossal nerve, its major function is restoring resting tone. As a transfer for creating smile, I don't think it works all that well, and this is why. Because to activate it, you have to press your tongue against your teeth or your palate, which is pretty unnatural, and most people that I meet that have had that transfer for smiling don't use it socially. So this is a lovely young lady, and she underwent excision of a very large acoustic neuroma, and she has a significant problem. She has both a facial nerve injury and injury to her trigeminal nerve or her 5th cranial nerve. And you can see she has some wasting in her temporal area, so that muscle's atrophying, her masseter muscle's atrophying, and she has no sensation on the left side of her face. It's completely numb. If you look at her lower lip, you'll see that she's been accidentally biting the lower lip because she can't feel it, and it's led to chronic ulceration of the lower lip that won't heal. You'll also notice that she has a very extensive tarsorrhaphy involving her eye. And that is because she has no corneal sensation. And if you have a cornea that has no sensation, ultimately everybody will go on to have significant visual loss. It's a major problem. And there she's just showing us the ulcer. So what we did for her, because her masseter nerve was not available, we did a hypoglossal to facial nerve transfer as a babysitter. And what do I mean as a babysitter? Well, the hypoglossal nerve is in pretty close continuity with or proximity to the facial nerve. So it only takes a few months for the nerve fibers to grow from the hypoglossal nerve into the facial nerve and facial muscles and rescue them. Again, it stops that time-dependent atrophy process that we were talking about. So you're giving those facial muscles a new source of innervation, and you're resuscitating them, and you're maintaining their health. And then that stops the clock and allows us to have a whole year for the nerves from the crossface nerve graft to grow all the way across from the one side of the face to the other side of the face. And so that's what we did for her. And I think you can appreciate, here's the 1-year follow-up. There's been some significant change. The corner of the mouth now came up to a normal position. Again, that's the resting tone from the hypoglossal nerve. And you can look at the parentheses marks, or the nasolabial folds, we call them. They're much more symmetric now. Also, in her particular case, we did something interesting where we took a nerve graft from one of the sensory nerves on her right side of her lip and brought it to the left side of the lip to restore her lip sensation. And I think you'll also notice that her ulcer in the lower lip is healed. So 1 year later, we go back to the operating room. And now when we explore the facial nerve and stimulate the branches, we can see what each branch does because it's been reinnervated by the hypoglossal nerve. So we'll stimulate branches and the eye will close, we'll stimulate branches, we can see a smile, and then we know where we should connect our downstream crossface nerve grafts. So this is her 18 months after the second phase. And the other thing that we did for her too is put in a small piece of muscle as a flap to give her a little more strength in her smile. This is a new program that we have at Houston Methodist. We've been working on this for the last 3 years, and it's a relatively new surgery called corneal neurotization. And as I mentioned, if you have a cornea that does not have sensation, then everybody will ultimately go on to have profound visual loss over time. And what we did in this surgery is we divide a sensory nerve on the unaffected side of the face. We use that crossface nerve graft like I showed you, but in this case, we break the end of the graft into its component parts called fascicles, and we wrap those around the cornea. And over time, the nerve fibers will traverse the face and grow into the cornea and give the cornea a new source of sensation. And it does more than that. It actually releases a series of protective chemicals, biochemicals that help maintain the health of the cornea. So this is very exciting. And we did that surgery on the young lady that we just showed you. All right, let's switch gears and we'll talk about treatment of late facial paralysis. So the one thing late facial paralysis cases have in common is that the muscle is no longer available to be resuscitated. It's too far gone, and we have to bring in a new source of muscle. That can be bringing in muscles from the leg, which we talked about a little bit, or sometimes using local muscles like one of the chewing muscles. But I find this to be a very useful technique, and we'll spend some time on this, and that is the use of free functional muscle flaps. They can be done in one stage where we use the chewing nerve to provide innervation and power to it, or we can do it in 2 stages where we put a crossface nerve graft, as I've showed you before, and a year later come back and connect it to the muscle flap. So here's an example, young lady. She's had 26 months of facial weakness. You can see there's a tiny little bit of retained function, but I would be concerned to try to do the reconstruction simply with a nerve transfer. I think we need a new source of muscle. And so this is what we did. We did a free gracilis muscle flap. So the gracilis muscle is represented here. We obtain it through a very small incision in the inner thigh, so the scar is well covered by shorts in the summer. The muscle is a very small, slender muscle, and there are several adjacent muscles that are very large that do the same job. So you can take it out without creating a functional problem. And we take just a small window of the muscle, and that window of muscle comes with its nerve called the obturator nerve in a series of blood vessels. And with the aid of microsurgery, we connect the nerves and the blood vessels so that the tissue can live in the new location. In this case, we used the masseter nerve, the chewing nerve, to give power to the muscle. And I also connected a few facial nerve fibers into it as well, just to see if we could get some effect. These surgeries are done under an operating microscope with tiny little stitches. And you can see here, if one of you came into the emergency room this afternoon with a laceration on the chin, I would repair it with a suture or a stitch like this. If I was fixing your facial nerve or doing this type of transplantation, I would repair the vessels and nerves with a stitch like this, which is about 1/3 the thickness of a human hair. So here she is, 8 months after completion of the transfer, and there has been some improvement. Here's another lovely lady, and she had an acoustic neuroma excised in 2011, followed by gamma knife therapy, and unfortunately had a recurrence. And so in 2015, she underwent re-excision, which she was left with a facial paralysis, which you can see here. And so I saw her 29 months after the second surgery. And so she is not a candidate for a nerve transfer, but I thought she would be a wonderful candidate for a free muscle flap innervated by the masseter nerve, and that we would also put in some fascia lata or some dense leathery tissue that we obtained from the thigh to try to create additional support for the cheek at rest. So here's my surgical plan. The yellow strips represent the fascia that we'll put in there for static support, and then the other part is muscle. Here she is after surgery, and there has been some improvement in the symmetry of her face at rest. She was a little nervous about doing the video, and so she said, you know, why don't we pretend we're taking a picture, and I'll count out 1, 2, 3 and say cheese, and then I'll give you a smile. So there we go. Here's another lady, again, a 61-year-old who's undergone excision of acoustic neuroma. She's 18 months out from the time of surgery, and again, I think you can appreciate she's quite weak on that side. Here's the surgical plan again, the functional muscle flap along with some extra support. And here she is very early after surgery, only 5 months. And so she's just learning to use that transfer or use that functional muscle, you know, getting in front of the mirror and doing the biofeedback exercises. So we can also innervate these functional muscle flaps, as I said, with a crossface graft. And the beautiful thing about that is it can give you truly spontaneous motion. Here's a young lady, she's 7 years old, and she has a developmental facial paralysis. So her facial nerve and her facial muscles just didn't form in utero on the left side of her face. So we did the crossface nerve graft. We waited 1 year, and now we'll be back in the operating room. We'll put in the muscle like we talked about, a little tendon for some support, and the crossface nerve graft will get hooked into the nerve that comes along with the muscle. And here she is after surgery. I think it was about a year or so. So I have a 14-year-old who loves to tell cornball jokes, so I like to share these with my patients. And I'll tell her a couple and see if we can get her to give us a good smile here. There we go. As I mentioned earlier, that our nerve regeneration abilities drop off as we age. And so we've, over the last few years, started using a technique to try to, again, create a marriage of power and spontaneity, where we get the beautiful spontaneity from the crossface nerve graft, but we also can import some power from the masseter nerve. And so here's a gal who had Bell's palsy. And not only is she weak, but she's developed something called synkinesis. So this happens with Bell's palsy and also happens with acoustic neuroma as well. When there's spontaneous nerve regeneration and the nerve fibers start growing back, some of the 7,000 to 10,000 fibers can make the wrong turn and crosswire and go to the wrong place. So that, for example, when you smile, your eye closes. And that is not uncommon. You can see here, she has pulling down to the corner of the mouth, which signifies that she has some of that synkinesis. So the plan for her is a crossface nerve graft. 1 year later, we'll go back to the operating room. We're going to do that functional muscle flap. But we're going to do dual innervation. So the crossface nerve graft will come into it, and we'll also connect the masseter nerve to it to try to take advantage of both of them. And here she is after surgery with some improvement. All right, we'll switch gears and talk about local muscle transfers. The most commonly utilized one is the temporalis muscle, which is a local chewing muscle here. you can use it in several ways. One way is to take a central region like I showed you here and just turn it over. Another way is to sort of mobilize the muscle from its attachments and slide it forward. It's called a lengthening temporalis myoplasty. Or sometimes we simply release it from the jaw and use a piece of that leathery fascia, extend its reach to the corner of the mouth. Here's an example of it, a lady with Bell's palsy. And here she is after the temporalis transfer. And I think you can appreciate we're able to achieve a little bit of improvement there as well. And interestingly, it's much like the Masseter nerve transfer. Initially, you have to clench your teeth to create motion, but people really can learn to make it more of a effortless, reflexive smile over time. Static procedures. Sometimes we'll see individuals who are just not good candidates for a lengthy surgical procedure, but they can tolerate something relatively short and straightforward. And so we do static procedures where we'll take, again, that leathery tissue from the side of the thigh called fascia lata, or we'll borrow expendable tendons from the arm or the leg. Interestingly, a certain number of the population, 8%, doesn't even have some of these tendons, so they're definitely expendable. And we put them internally to create support. And you can achieve things like this, where although the face doesn't move at rest, it can be much more symmetric, and it can improve the situation from a functional standpoint, just keeping food and saliva in your mouth, for example. Restoration of eye closure is really critical. Certainly, if you can't blink and protect your eye, you can go on to get exposure keratopathy and even corneal ulceration and blindness. And so there are multiple ways we can achieve this. One is, the most common way is using eyelid weights, either gold or platinum eyelid weights. Some places will implant springs. I'll show you some crossface nerve grafts that we've used to do this. And we've also can do functional muscle flaps and muscle grafts as well. But here's the gold eyelid weight. And this lady is trying to close her eye, and you can see the eyelid won't close, but the eye is rolling up to try to protect itself, which is called the Bell's reflex. And in the clinic, we have these external eyelid weights and two-sided tape. And we simply put the weights onto the eyelid, as you can see here. And we're looking for the weight that will close the eye completely, but at the same time not make the eyelid droop. And so here she is with her eyelid weight on. And you can see that it closes the eyelid nicely. But if you look forward, look at this, it's not drooping. And then we simply just implant the weight underneath the eyelid skin and muscle. And it's a relatively quick procedure. It takes about 30 minutes. Here's a young lady that has inability to close her eye completely. You'll see here in a second. And here she is after insertion of an upper eyelid weight. We can also achieve this with crossface nerve grafts in certain cases. And this is the first patient I showed you at the opening of our discussion today. And here she is able to close her eyes after the crossface grafting. All right, so the other thing I'd like to talk about is restoring lower lip depression. So there are muscles that lift our upper lip up to show our teeth, others that contract towards the root of the ear to move the corner of the mouth. And then also we have muscles that depress the lower lip to show the lower teeth. And I think if you look at certain people's smiles like Julia Roberts, you can really, really see that. And so when we're trying to create lower lip symmetry, we have two choices. We can weaken the unaffected or strong side to match, which works well in some people. And we do that using Botox. If people like the effect, then we can make it permanent by removing a little window of muscle. And we do that through an intraoral approach, so there's no visible external scar. Alternately, if we want to try to restore the lower lip depression, we can transfer the anterior belly of the digastric muscle, which you see here in this illustration, or we can use the platysma muscle in the neck sometimes, or even small nerve transfers. But this is an example of a myectomy. You can see he's strong on his left side, and to make it match, we simply took out a little window of muscle. We touched on synkinesis before, but again, just to regroup, when facial nerves regenerate spontaneously, they're full of nerve fibers, 7 to 10,000 of them. And they follow a series of biologic channels or tunnels as they try to make their way back to the facial muscles. And sometimes they just make the wrong turn and head in the wrong direction, and you get a series of cross wiring, and that causes unbalanced muscle function called synkinesis. And the most common one is oral ocular synkinesis, where people pucker their lips, like using a spoon, for example, or smiling, and it will result in closure or blinking of the eye. We treat that often with Botox, which can be very effective. And sometimes we'll also do things called selective neurectomy, where we cut the motor nerves to try to dampen the amount of neural input to those muscles. And here's an example of a nice lady. She has synkinesis in her neck. So every time she blinks or smiles, the muscles in her neck all spasm, and it's painful, and cosmetically she doesn't like it. So we did selective division of some of those nerve branches to that platysma muscle in the neck. And here you can see the result is a significant improvement. With regard to the unwanted eye closure with smiling, we also often do crossface nerve grafts for that in an effort to sort of dissociate the mouth from the eye. This is another type of synkinesis where you see this dysfunction in the lower chin and the lower lip. So the chin lower lip subunit is having a problem. And what's going on is this is the mentalis muscle, and it's a chin muscle that holds the chin, supports the chin. If too many nerve fibers grow into it, it actually pushes the chin up, and you can see it's pushing the lower lip up over the teeth in her case. We have a muscle called the depressor anguli oris that pulls down the corner of the mouth. In this case, it's become too powerful. Too many nerve fibers have grown into it, and it's pulling down the corner of the mouth, creating that look. As you can see here, instead of the corner of the mouth coming up, it's actually trending down, and it's resisting the muscles that are trying to lift the upper lip up. The orbicularis oris is contracting, and the muscle that's responsible for depressing the lower lip is too weak to do its job. So there's this imbalance. We call it the zeta deformity because it looks like an inverted letter, Greek letter Z. But again, there's this imbalance in these situations between the muscles that lift the lip up and the muscles that depress the lip. And if that tug of war gets unbalanced, then you lose your facial symmetry. Here's a kind of a subtle example of it. This is a gal that had Bell's palsy. And again, you notice the corner of the mouth goes up nicely here, but in this case, it's trending downward as that overactive muscle is pulling down the corner of the mouth. And by simply putting in 4 units of Botox, which is a very small amount, you can see we've weakened that overactive muscle, and it allows for a much more symmetric smile. We also have surgical treatments for these things. Often we'll transfer one of these muscles, the depressor anguli oris muscle that's overactive, to the weak muscle to give it some strength. And we'll also divide the nerve fibers going into the chin muscle or into the chin muscle to prevent it from contracting and fasciculating. So here's an example. Here's a lady that has that zeta deformity. You can see the chin is pushing the lip up. The corner of the mouth is being pulled down by the overactive muscle. And in her case, we did exactly what I said. We will transfer her depressor muscle over and divide the nerves to the chin. And here she is after surgery. And I think you can appreciate there's a lot better harmony in the lower lip and chin area now. And I will tell her one of Jack Klebuc's famous jokes here, and we'll see if we can get her to laugh for us. Yeah, there we go. So now you can appreciate the lower lip is contracting. So I think I'll just leave you on this philosophic note, and that is, sometimes your joy is the source of your smile, but sometimes your smile can be the source of your joy. And I like that quote. And I will thank you for your very kind attention.
All right, Dr. Klebuc, thank you so much for